that have relatively little to do with what we're talking about tonight. For starters, we're really focusing on stinging insects. Biting insects, some people get allergic swellings that are pretty nasty, and they can be allergic, but it almost never causes anaphylaxis, and there really aren't any commercially available tests or specific treatments. The big deal are the stinging insects, all of which are from the order Hymenoptera. That includes the bees and vespids and ants, stinging ants. So the fire ants, imported fire ants, are the main ones in this country. There are others around the world. They are different because they do sting, and they are family to the other stinging insects. And I'm going to say very little specific about fire ants. Despite some differences, the basics are kind of the same as far as the reactions and the testing and the treatment. Most of what we deal with are the vespids, mainly yellow jackets, some hornets. The true hornets, European and Oriental hornets, are very few in this country and not that many in other areas. And the paper wasps are cousins to these guys. In other words, when we talk about the testing and treatment and allergy reactions, if you're allergic to yellow jackets, there's a very good chance you're allergic to hornets, and there's a 50-50 chance you're allergic to wasps because of the relationships. On the other hand, if you're allergic to yellow jackets, it has nothing to do with honeybees. They're not related. It's a different group, just like the fire ants are a different group. This is a honeybee, nice fuzzy body, kind of indistinct stripes, very unaggressive. No one gets stung by a honeybee unless they step on them or grab them with their hands or annoy their nest. On the other hand, yellow jackets in the upper left are often very aggressive, and if you disturb them with vibration or disturb their nest, they will swarm and attack. On the lower right is actually a type of paper wasp. The point is that there's a kind of a wasp that looks very much like a yellow jacket. And it's one of the reasons that when people tell us they're sure what stung them, studies show that both people and patients and individuals and doctors and all of us are really not very good at telling one apart from another. I've had a lot of training from insect scientists, so I'm pretty good at it, but mostly you don't stick around to find out what stung you. This is a so-called white-faced hornet or bald-faced hornet. They make those big football-shaped nests up in the trees, and they are definitely bigger and meaner and more painful. But like I said, this is the kind of nest they make, but they are, in the end, very, very closely related to yellow jackets. And these are those fire ants that build mounds. If any of you who live in the southeast part of this country or Gulf Coast know very well about fire ants, because you can't live in those areas for very long without getting stung by fire ants. You can hardly let your kids play outside in some of those areas. And although they're just little ants, they pack the same punch as a stinging insect. As we go through this, I'm going to try to use some examples and cases to illustrate where we're going with the things we're going to talk about. So, for example, a 12-year-old boy was on the school cross-country track team, and they were running in a wooded area, and he got stung twice on the arm. Within 5 minutes, he got tightness in his throat and broke out in hives and had swelling in the face and dizziness and trouble breathing. So they helped him back to school, and they were met by paramedics thanks to the cell phones, and they gave him epinephrine, and he was fine. So we'll talk more about venom immunotherapy and why it is really the only and best treatment for people who are in danger of severe or anaphylactic reactions to stings. But some of the questions that came up quickly with this boy was, well, because we hear this all the time, well, he doesn't really need to be immunized because he'll outgrow it. Some people would say, well, venom immunotherapy is way too dangerous a treatment, so it's not worth it, or that it really doesn't work that well, or that you have to be on it forever. The answer is none of the above. There's not such a good chance he's going to outgrow this, unfortunately. Venom immunotherapy, as we'll discuss, is as safe as any other kind of allergy shots, if not even maybe a little safer. And it is almost 100% effective. And most people only need it for a few years to get a kind of permanent immunity. So we'll come back to some of those details as we get closer to the actual treatment. But what about this boy's reaction? Was this typical for his age? Actually, no. When we look at the typical things that occur in anaphylaxis, which, to do a quick definition, is a usually multi-system allergic reaction that is potentially dangerous. Cutaneous or skin only means that they just break out in hives or their face swells, but there's no trouble breathing, which you see lower down here, or the blood pressure problems, dizziness, and actual loss of consciousness. So the three main categories here are skin reactions, including hives and swelling, or airway reactions like trouble breathing, wheezing, throat tightness, and hoarseness, or the circulation, like the dizziness or even loss of consciousness. So what we noticed years ago, decades ago, was that although you see in adults that pretty much half of them had the throat and breathing problems, 30% actually had loss of consciousness, and a lot more than that had significant drop in blood pressure or dizziness. But that stuff is quite rare in children. You see very few having the blood pressure problems. You see a lot of them still having the throat and breathing problems. But there's also this big difference where a lot of children, like this 12-year-old boy, break out in hives and get face swelling, but they don't get the other problems. It's really almost not anaphylaxis if it's only on the skin. And that's not so common in adults, but very common in children. So this boy's reaction was definitely more severe than what we typically see in children. And that's why he was advised to go on Venom immunotherapy and did quite well with it. How long does it take for a reaction to start? Like almost all anaphylactic reactions, there's usually the early signs of the beginning of the reaction within 10 to 20 minutes. And if we extend that to 30 or 40 minutes, then it really does encompass almost all the reactions. But you see here, this was a registry of about 3,000 insect allergy patients from back in the 80s. And you see a few that didn't happen, that didn't seem to start until an hour or two after the sting. And although that's rare, there is such a thing. But it is pretty rare. So much so that we would tell most people that if nothing's happening within 30 to 40 minutes of the sting, it's very unlikely that you're going to land up with a bad reaction. That's not always true with foods, but it's much more so the case with insect sting anaphylaxis. This brings us into what is normal procedure. What are the best things to do in treating the reaction and then counseling the patient. So these are emergency room studies. Actually, on the left are the food allergy studies. On the right is the insect sting allergy studies by Carlos Camargo's group. He's an emergency medicine specialist who's interested in allergies. And first of all, this is a good time to mention that there really is only one main treatment for anaphylaxis and severe allergic reactions to stings, and that's injectable epinephrine. Some people will need intravenous fluids and oxygen, which are also important, but number one by far is epinephrine, and we'd like to assume that patients were treated in the emergency room with epinephrine. We know that's not always the case, but in emergency rooms they certainly have a lot of resources, and I'll give them credit that they take good care of the patients, but we sure wish they would use epinephrine more readily. But then what do they tell the patients? They should be telling them, according to all national and international guidelines, to avoid, what can they do to avoid the allergy, meaning the stings. Panel B is they should be prescribed injectable epinephrine and given advice on how and when to use it. And they should be referred to an allergist to be evaluated for knowing what's going to happen in the future and whether they need other treatment like Venom immunotherapy. Well, as you see, emergency rooms around the country did an awful job, even worse for insect sting allergy than for food allergy, of recommending these things to patients. There were 2 or 3 emergency rooms that did pretty well. I'll bet one of them is Dr. Camargo's institution. There were some that just didn't even make the chart, didn't do any of these things. As allergists, we try to, and have been for years, to kind of penetrate that emergency room medicine specialty area to try to get them to do better. They're busy. It's hard for them to do this, but I don't know why they can't just generate a computer printout like they would for head injury, let's say. So we still have work to do in getting patients to get the right advice, which is why, as allergists, we don't see but the tip of the iceberg, actually. For every person that comes to us for insect allergy, there's probably 5 to 10 out there who should be coming to us, but we're never told. And amazingly, the great majority of primary care physicians have not been, it's not their fault, they were never trained in a lot of areas of allergy, least of all knowing that venom immunotherapy even exists. So although they've done a much better job in primary care over the years of the epinephrine prescribing, and we've seen a major improvement there, uh, the details and availability of venom immunotherapy is something we still need to spread the word about. And a lot of times it's patients coming to me because they read about it on the internet rather than having some doctor tell them that this is available and they should see an allergist. When the doctor, any of us, allergist or non-allergist, is evaluating someone for allergies, although most of what I'm going to say here is what the allergy specialist would do, the big question is what's going to happen next time. And a lot of what I'm going to say is about this prediction of risk, because it's certainly not that easy or that obvious, as you'll see in some cases. But basically, the history is paramount. A lot of this has to do with the details of what kind of reaction they had and how bad was it. And we, of course, need to do tests to confirm the allergy. It's important for us to know what happens if they don't get immunized. Like I said, will they outgrow it, or does it get worse with every sting? And the answer is no to both of those.
Hey,
We'll come
Dr.
back to that.
Golden.
Yes.
I just have a question from Scott Ehrman. He
Yes.
has allergies to insects, and he wants to know what allergy test he would need from his allergist.
Good question.
To confirm that.
And I will actually be talking in a minute about both skin tests and blood tests, because those are the kind of allergy tests that he would need to detect whether he's allergic to honeybees or yellow jackets or wasps. On this slide, we mentioned skin tests or serum tests, meaning blood tests, both of which are very good tests. The skin tests are a little more accurate, but both are commonly in use. And I'll talk a bit about what that says to us. The allergist will also focus on measuring something called serum tryptase, because some of the worst reactions happen in people who have an imbalance of the allergy cells, and that's what we're measuring. And then there are softer issues, so to speak, but they're also important about what we call quality of life. Does this allergy prevent people from going outdoors or going to picnics, or because that's sometimes an important reason to recommend certain treatments. And I'll go through some of these details quickly. I've already mentioned, and maybe I'll bypass some of this, that in the children it's more likely to be the milder kind of reaction, whereas the very severe reactions are uncommon in children. And as we get older, we actually get more susceptible to the more severe reactions. There are, of course, some fatal reactions every year, 50+ deaths per year in this country from insect stings, which actually is less than we might have worried about. Fortunately, even the worst reactions usually run their course, but the majority of the deaths are in, I hate to say older individuals because it now includes me, but that's the pattern for some of the worst reactions. How do we predict what's going to happen in the future? Well, as I said, the history itself turns out to be one of the most important things. So this was a study where we stung people with yellow jackets and so on. And what you're seeing is that depending on whether they had relatively mild reactions like hives and swelling, or medium reactions, moderate with some throat tightness or dizziness, or severe, meaning near unconsciousness or severe trouble breathing, well, the worse the reaction, the more the chance that they were going to have a reaction to the next sting. So how bad the reaction was tells us something. And part of what that's saying, and this is a question that I received from one of the participants in advance, is it going to get worse every time I get stung? Because that's something people get told a lot, that the next one's going to kill you. And actually, that's not so common. The worse it was before, the worse it's going to be next time. But I'll come back to another slide to show you a study where we found that people don't commonly get worse and worse with each sting. It can certainly happen, but it's not that common. So how bad the reaction was is important. We're coming closer to those test questions, but here's another case to bring us to that. This woman requests that she wants to be tested for insect stings, for venoms, because her cousin had a near fatal reaction and she's been avoiding outdoor activities and she's obviously very worried. She thinks she was stung as a child, but she really doesn't know. So what do we tell her? That we isn't that we don't recommend to be tested, or that she should carry an EpiPen, or that she should have blood tests. And the answer actually is that we don't recommend that she be tested. People who have not had reactions, the reason we don't recommend to be tested is because you might find something that you don't know what it means. As allergists, we always ask ourselves, what are we going to do with the result? Because we shouldn't do the test if we don't know what we're going to do with the result. So what if this lady has a positive skin test? What does that tell us? Is she going to have a reaction to the next thing? Actually, there would be only a very, very small chance that she would. It so happens that if you get stung tomorrow and I do a test a month later, that there's a 40% chance it's going to be positive. It'll probably go away by itself. If we didn't go looking for it, we wouldn't even know it was there. And that's just kind of a normal response in many people, but it's not necessarily going to turn into an allergic reaction. There are actually a lot of people who have positive tests for peanut, but they eat it all the time. So this is very confusing, even to allergists, because we don't know why some people have the allergy in their system and don't react. There are other tests we need to develop to tell us more about that. So that's a little tricky. This woman will not be happy with my answer, but I'm going to try to explain to her why we really don't think we should test her. Because if I test her and it's positive, now she's going to be really scared and she's going to demand treatment. And we're going to question whether that's necessary. So we have to really ask ourselves in advance, what do the tests mean? So here's the point, that the tests are often positive in people who have never had and may never have a reaction. That even people who had reactions and have positive tests don't always react to a sting, but their chance is much higher. Meaning if they have a 50% chance of reaction, then we should treat them. But if someone has a 10% chance, that's a bigger question and a difficult question about whether it's worth immunizing 100 people if only 5 of them are ever going to actually have a bad reaction. So this is an example of what the tests do tell us. This is looking at skin tests, but the graph for the blood tests is kind of the same, meaning that the stronger the test, so this is someone who has a very strong positive test, and those people had a much higher chance of reacting to a sting than these people who had milder tests, or these people who had a negative skin test but a positive blood test. They still have the allergy, but the milder the allergy, the less the chance of reaction to a sting. Now that's tricky because I said chance of reaction. I didn't say how bad the reaction would be, and that's not so predictable. And I think, no, that's not this next slide. So to finish that thought, it's something not totally understood about the body that can make the reaction be bad or not as bad. So some people have a very strong allergy, but they have a not so bad reaction to a sting, and others have what looks like a pretty mild allergy, and then they have a near fatal reaction to a sting. So we have to keep in mind that the test is very useful in many ways. It tells us what they're allergic to. It tells us what chance there is of a reaction, but it doesn't totally tell us how bad the reaction might be. That's what the history tells us. So remember this slide that said that how bad the reaction was would tell us the chance of reaction. I should have said it also tells us that there's a more chance of a severe reaction, because severe reactors tend to have severe reactions, and as I was kind of mentioning, people with milder reactions don't usually get worse. I mentioned that blood tryptase, saying that some people have a kind of imbalance of the allergy cells, and this was a study that showed that the higher the blood test for tryptase, the more the chance of a really severe reaction to a sting. And that's worth knowing, and that's why we're trying to encourage allergists to do this blood test as well, to help identify people who are at the highest risk for severe reactions so we can make sure they get immunized and protected. Let me bypass this. It's a little more detail about why the tryptase tells us that people are at greater risk. I think we can move on to this case and talk further about the details. So this is a woman who remembers that as a child that she had a reaction where she had hives and swelling of the lips, but none of the other anaphylactic symptoms, but now she's really worried about it because she read about a man who died from a reaction to a sting. And what do we tell her? Do we tell her, oh, yes, you need to be immunized, or, oh, you were a child, you must have outgrown it by now, or, oh, you should just carry an epinephrine kit? Um, and that leads us to some other differences between children and adults, which brings us right into, okay, venom immunotherapy, which I'll describe in a little more detail soon. Um, who needs to be immunized? And this is, again, basically a form of allergy shots, like people might get shots for grass allergy or cat allergy or dust allergy. This is venom allergy shots with purified venom from honeybees and yellow jackets to build up an immunity that blocks the reaction. We'll come back to some of the details, but who needs it? And officially, someone who has had an allergic reaction to a sting and has the allergy showing on the skin test or blood test should be immunized. But like, how bad a reaction does it have to be? If it was life-threatening, sure. If they had even moderate breathing or throat or dizziness issues, sure. There get to be some question marks about if it was just hives, do they need to be immunized? I didn't say yet anything about large local reactions to stings where you get stung on your hand and you wake up the next morning with swelling up to your elbow or your shoulder. Those are huge swellings. They're not systemic, they're not anaphylactic, but they sure are distressing. Do they need to be immunized? And we'll touch on each of those in a minute. The way we figure this out is by stinging people, or at least we used to. We don't see a need to right now. That's a research procedure. And it's obviously a very direct way of finding out whether someone is likely to react or not, and developing some better indicators for that. So that's actually what we did to develop this kind of overview table. And these are the categories I was talking about, of what kind of allergic reactions people can have. So the people who have had the life-threatening reactions where they couldn't breathe or they were in shock, their chance of reaction is very high. It really approaches 75%. It's not always going to be severe. Maybe only 30% of the time is it going to be life-threatening, but that's pretty risky. Whereas the medium kind of reactions have less chance of reaction, but still approaching 50%. And definitely less chance of it being severe, but still around 10%. But what if it was just hives and face swelling, for example? Turns out that in children, there was one big study at Johns Hopkins that showed that they have relatively little chance of having any systemic reaction, less than 10% chance, and that's almost always going to be less severe than it was before. They might get some hives, but the chance of actually needing an epinephrine injection because of a worse reaction is less than 3%. So we actually don't recommend testing or treating children, which was officially under age 17, who have hives or swelling, even though it looks really scary. We try to explain to the parents and family that there really is only a very small chance of a severe reaction in the future. Although I guess if it scares them enough, we're willing to do the immunotherapy. I mentioned quality of life, and this is one of those examples if it's going to really radically change their quality of life. But we feel they don't need it. I guess that's all statistical. If 3 out of 100 are going to have a bad reaction, then it's too bad we don't have a test that tells us which 3, because we don't want to treat the other 97. But we have no test that exactly tells us that, so we, together with the family, have to make judgments on whether we're going to accept this risk and maybe carry an epinephrine injector versus go ahead with the shots. What about adults who get these hives and swellings? I showed you early on that that's not so common in adults like it is in children, and there's no official study on it, but what we think we know from stinging a lot of people is that their risk is definitely less for having any reaction, and not that much worse than the kids for having a worse reaction. But there's still a lot of feeling that we should offer the shots to the adults with these reactions because we know that some of them will get worse. But I will tell you that around the world, mostly the decision is to do the same as the children because the risk is relatively small. And lastly, about large local reactions, those huge swellings that are not dangerous, but they are very nasty. If you have that kind of allergy, is there a chance that it could go on to the next thing causing hives or trouble breathing? And the answer is yes. 5 to 10% chance of hives, 2% chance of trouble breathing or severe reaction. So again, that's not zero, and some of these people will develop worse reactions, but the recommendation is that it's just not enough chance to take all those people and put them on shots. So those are the ways that we've learned about. This is called natural history. What happens if you don't put them on shots? What's the chance of something happening? And that's part of how we decide who really needs the shots. Though obviously there's some judgment and discussion with the family on why we do this and what would work out best. Again, to bypass this real quickly, it's just a point that when you get stung once, someone who is allergic could get stung and not have a reaction, and then if they were stung again a month or 2 or 3 later, they still might have a reaction. And that's probably because one yellow jacket sting can be not as strong as another yellow jacket sting, for example. But it fools us sometimes. It fools patients into thinking, oh, well, I got stung and didn't have a reaction, so I'm okay now. Unfortunately, that might not always be true. And we have to keep that in mind when we evaluate our patients. And this is the one of the only studies that looked at that question I said of, is the next one going to be worse? And in this case, for example, of all these people with previously mild reactions, only 2 got worse. None of these people with medium reactions got worse. In other words, only these 2 out of these 259 people stung actually got worse on a subsequent sting. And there's one other study that kind of showed the same results. So it's not so common to get worse and worse and worse on subsequent stings. I'm not saying never, but it actually is. It's not like that's the norm. It's not the norm to get worse and worse with this kind of allergy. The quality of life is an interesting point. The reason I wanted to show this slide is because although it's not surprising that the people who were put on the Venom immunotherapy had a major improvement in quality of life because they felt so much more safe, the interesting thing was the people in this study, this was a randomized study, so like some of the people got the shots, some of the people were not given shots and were given just an epinephrine injector, and their quality of life actually deteriorated. They did not feel safe. So it's just a point that there are a lot of benefits to Venom immunotherapy in the people who need it, and just giving them an epinephrine kit is medically wise because at least they have something they can do if they get a severe reaction, but that doesn't necessarily make them feel secure, and that's kind of important for quality of life, which is a lot of what we do. Another question I had in advance from one of the attendees was whether to use an epinephrine injector the minute you get stung. And you hear different things about when to use it. I thought I would bring this up right now because we're talking about epinephrine kits. And that's really an individual judgment. If you're not on the Venom immunotherapy, because if you are, then you shouldn't need the epinephrine kit. If you're on the allergy shots for Venom, there should be almost no way you're going to have a systemic reaction to a sting. That's the beauty of the treatment. But if you're not on the shots, it depends. If you've previously had mild or medium reactions, like I said, you may not even react to every sting. So you should have the epinephrine ready, but if you start to break out in hives and you know you've gotten worse in the past, then maybe you should use it at that point. Certainly, if there's any tongue or throat discomfort or breathing or dizziness, for sure you should use it immediately and call 911. On the other hand, if your last sting put you into shock and you almost died, I would say use that epinephrine kit immediately and call 911, and why aren't you on the shots yet? So the advice is not the same for everyone, but those are the things we think about in telling people when to use the epinephrine kit. And I'm sure some of you may have questions about that I'm glad to answer shortly, I hope. And this is kind of just a summary because I get questions all the time from allergists and physicians. It's kind of obvious that epinephrine should be prescribed to people at high risk because they've had such severe reactions or because they're not yet on the shots. I mentioned that tryptase test if it's elevated, but there are a lot of people who I pointed out are at low risk. because they're large local reactors, or because they're on the shots, or because they had the shots before? Do they all need epinephrine injectors? Now, every one of these people has a chance of reaction to a sting, but if that's a really low chance, then it's another one of these judgment calls that ideally we really have a discussion with the patient about um, how much risk is acceptable, and whether they'd feel a lot better having an epinephrine kit. Because having one and carrying it around and sending it to school is not benign. It's a burden in a sense. Uh, on the other hand, if they ever need it, we'd like them to have it. So obviously, I'm not giving you a black and white answer on that. Many people would feel that if there's any chance of reaction, then that little lawyer looking over your shoulder, I apologize to any in the audience who are attorneys, but that's the reality, is that if there is a risk, that why shouldn't we kind of cover our bases and give them an epinephrine injector? And part of the answer is because it's almost $400 a shot at retail price. But nevertheless, it's someone's life, and I'll leave it at that. It is one of those kind of judgment calls. Okay, back to another case. This 32-year-old man has a history of severe and prolonged swelling from previous insect stings, those large local reactions I was talking about. But this time, after 15 minutes, he breaks out in hives and gets lip swelling and hand swelling. No throat tightness, no dizziness. Things go away by themselves after an hour. But the next day, he goes to the emergency room because of that huge swelling, and they put him on antibiotics. Is that the right treatment? Or looking at the bottom of the slide, should it have been prednisone steroid or antihistamine or Venom immunotherapy, or should they have given him an epinephrine shot? Well, large local reactions are not infections. They look like cellulitis to a doctor, but if the doctor's really thinking about it, there's no way you get an infection in 24 hours. It's pretty rare to get an infection from a sting, but if it was going to get infected, it would take several days. The treatment, if anything, are the steroid pills, because that's the only thing that might really make the swelling go down, although it will go down by itself, although it can take 7 to 10 days when it's really, really big, and it can be quite disabling. So antibiotics are actually the wrong answer to that question. One little pointer that I always like to make to everybody is this little clip from the New England Journal of Medicine that described a 57-year-old man who came to the emergency room with chest pain. And they ruled out a heart attack, and they called in the stomach specialist because they thought maybe it was inflammation in the esophagus, which they did not find. But when they looked a little further in the stomach, this is what they found. This gentleman was drinking from a soda can, and you can imagine the rest. Yes, he swallowed a yellow jacket and got stung in the stomach, and that caused his chest pain. Fortunately, he wasn't allergic. If you get stung in the tongue or throat and you get a large local reaction, you can get totally blocked up with swelling hours later. It's never good to get stung in the tongue or throat, but if you're allergic, it's a pretty scary thing. So we always try to make sure people think about not eating without looking, not drinking from straws or cans or anything you can't see inside of, because yellow jackets just love going into straws and soda cans and beer cans. I see at least one patient a year who has that kind of experience. So good advice for all of us. Venom immunotherapy, before I go into the details I've been promising you, for people with anaphylaxis. Yes?
Dr. Golden, from Sharon Jones. She says she had a student who used to use insect repellent wipes prior to going outside sometimes. He was allergic to bees. Is this a good practice or evidence-based? Should Benadryl be given as the first line of defense?
There's nothing that repels yellow jackets. They couldn't care less about insect repellents, unfortunately. It's also not true that they're attracted to brightly colored clothing or perfumes. They are very attracted to food, and that's the number one reason that they hang around. Benadryl as a first line of defense depends what you mean, because if you're having a systemic reaction and it's really only hives and swelling, then yes, you can take antihistamines, and after an hour or so it'll start to help. But any anything more into the area of anaphylaxis, tongue or throat discomfort, trouble breathing, dizziness, Benadryl is essentially useless. It should never be used as a first line. Epinephrine is the first line for those reactions. Now, as far as taking Benadryl before going outside or before exposure, in this case, I don't see the point. Hopefully, you're not going to get stung if you're careful. But if you mean as the first step for a reaction, only for the mildest reactions. It should never be used as a first line for anaphylaxis. Venom immunotherapy is not normally offered. I said that earlier, to people with large local reactions because they have a pretty low chance of having a worse reaction. But then there are people who, gardeners and landscapers and they're golfers who hit in the rough a lot, who get stung every year. And if they get large swellings every year and they need steroid treatment every year, is it possible that the allergy shots would actually help them? So we did that study some years ago, and the answer was yes. It greatly reduced the swellings. It's not worth it for the person who only gets a swelling every 10 years, but it's very much worth it, and we do recommend it for someone who has unavoidable stings and gets severe swellings and really needs some help with that. Then actually, yes, it does work and may be worthwhile. But the main reason for venom immunotherapy, as we said earlier, is for people with the systemic and anaphylactic reactions. Some of what I'm going to say is aimed primarily at the allergists, so I'll try not to overdo that. I'm not sure how many on our physicians or non-physicians, so I'm trying to kind of give a little bit of everything. When we start the allergy shots, the point for allergists is that we know that it's safe to start at a moderately high dose. It's not necessary to build it up for many, many months. We can actually have someone fully protected in 6 to 8 weeks, which is pretty quick for allergy shots. We do recommend taking antihistamines the day of the shot because it does cut down on some of the itching and swelling from the shots. And the recommended dose is 100 micrograms of each venom, but there are recent studies that show that we can give half that dose to kids. And that's important because kids have little arms and they get bigger swellings, and it's nice to be able to give them a lower dose and know it's going to work. This is actually a follow-up to that boy who was running on the track team. He starts on the venom immunotherapy and has no problem with reactions during the build-up period, but after that build-up, they're supposed to get a shot every month. And on the second monthly dose, he does get a systemic reaction and needs epinephrine. It's not real common, but when that happens, this is one of the problems with any kind of allergy shots, is the possibility of an anaphylactic or systemic reaction to the shots themselves. But what allergists will do is readjust the dose and build it back up again, or give other medicines to help block the reactions. In this case, we don't recommend just giving lower doses to avoid reactions, because if we give lower doses, then we don't know that they're fully protected. It's really critical with venom immunotherapy that everybody has to get the full dose. And so those were some of the points to know about possible reactions to the shots and what we try to do about it. In more detail for the allergists is that we sometimes use different regimens or schedules of treatments, giving a cluster of shots or doing a 2-day rapid or rush venom immunotherapy, often in the hospital to build it up, because that can get people up to full dose. It's not so much because we do it faster, but because doing it that way can actually work even in people who have had problems with reactions to the regular schedule. And then Xolair or omalizumab is a drug that can help block the reaction. So there's a lot of little ways and sometimes big ways of getting people immunized even if they're having trouble building it up. And again, for the allergist, this is an example of that 2-day rush schedule where there's a series of injections every 15 to 30 minutes. So it can build up in a couple of days to the full 100 microgram dose, and then they just have to continue with their every week or 2 or 3 and monthly treatments. What if the full dose isn't strong enough? There are a few people, like in this study, who, even though they were on the shots, when they got stung, they still had a systemic reaction. you can kind of see that they almost all weren't as bad as before the treatment. One or two of them were. So what they did is they gave them a higher dose. They went from 100 micrograms to mostly 200 micrograms, and then they didn't react, except for this one patient who actually needed an even a little bit higher dose. When there's a so-called treatment failure, which is very uncommon, a little more so in honeybee. I will point out for any of you who are beekeepers or worry about honeybee allergy, that it's a little harder to get the full protection with honeybee. And honeybees actually inject more venom when they sting you than a yellow jacket does. So when it doesn't fully protect the patient, we know that we can increase the dose and get that protection. A quick note that there's been a lot of fuss over whether being on certain blood pressure medicines, like the top two lines here, beta blockers and ACE inhibitors, because it was found that, without going into all these numbers, that being on those medicines seemed to be a risk factor for more severe reactions to stings. And it is important, but more recent studies are telling us that those medicines aren't such an issue for the shots themselves. And that's important because there's been a lot of concern that if you go on allergy shots, you have to be taken off your blood pressure medicine. And the most recent studies are saying that that may not be such a big deal. But when you're not on the shots and you're allergic to bee stings and you're on these medicines, they do increase the chance of a more dangerous reaction, and it's important that we know that.
Dr. Golden, we have one more question.
Sure.
I'm going to read it, and I don't understand it, but I'm hoping that you will. So it's skin test positive to 1 mcg to all, RAS test negative to all, 5 venoms, question mark, VIT, question mark, history, question mark, worried because of family history.
Yes, I understand all of that.
Okay.
Well, let's see. First of all, what the question is that the skin tests are positive to all of the venoms, 5 venoms, honeybee, yellow jacket, 2 hornets, and wasp. Those are the ones we always test with. And they're relatively weakly positive at just 1 microgram. But remember what I said about the fact that that doesn't tell us how bad a reaction somebody could have. That's all about the history. So as the questioner mentioned about history, that's perhaps the most important question. How bad was the sting reaction? Up to 20%, depending on the lab, of people with a positive skin test have a negative blood test. So the fact that the blood tests are negative doesn't faze me. We're back to history here. And what if the patient says, well, yeah, I did react to a yellow jacket. Does that mean that they only need yellow jacket? Depends who you ask. The late Bob Reisman, who was one of the experts in the field, would have said they only need the one thing they're allergic to. And other people like me will say, well, I'm a little nervous about that because if I don't give them shots for honeybee or wasp, then how do I know they're not going to react? And there's certainly some people who will. If you're allergic to one kind of venom and you have the other allergy in your system, then there's certainly some increased chance of reaction. So the official recommendation is that if they have a bad enough history that they need to be on shots, then they should be on shots for everything that shows on the testing. So I think that addresses the different parts of the question.
Great, thank you.
The next and last part of this is how long do they need to be on the shots? And there's a lot of talk about whether 3 years is enough, or do they need 5 years, or how do we know? Do we do certain tests? And I hate to sound like a broken record, but the most important question is the history, because the skin tests and blood tests actually don't tell us whether to stop the shots. That tryptase blood test is important because, as I keep saying, if that's abnormal, then their whole system is overactive for allergy, and they should stay on the shots, sometimes forever. If the history is bad enough, like a near-fatal reaction or severe trouble breathing or near unconsciousness, then we know that those people have more of a chance that they might have a reaction after they stop the shots. Again, one of the questions I got from a participant in advance was a couple of questions about whether to stop after 3 years or 5 years. But the question that came through was a little twist on that, and that's why thought I would bring it up in case people have the wrong idea. Because the questioner asked me, is it true that allergy shots only last about 3 to 5 years after they end? And the answer is no. The protection, these shots are almost a cure. For the majority of people that we treat, we know they can stop the shots after 5 years. They have a small chance of reaction, but it's almost certainly going to be way less than the original reaction. If they don't have any of the high risk factors, there's almost no way they're going to ever have another severe reaction, ever. And we have kept track of people for up to 13 years of being stung after they stop the shots. And we can say that this tolerance, which is the word that we use, or immunity, is very long-lasting in children and adults. So, for the most part, the answer is they can stop after 5 years, and there's about a 10% chance of reacting to a sting, but they are almost always, as shown here, way milder than the original sting, usually minimal. These people who had more severe reactions, that was before we learned our lesson, and our lesson is this slide, the high risk factors. If they were really severe, or they had bad reactions to the shots, or they have this tryptase problem, then they're at higher risk. I already said that honeybee allergy is a little harder to get a full protection, so beekeepers are often recommended to stay on the shots for longer than 5 years. And that's it for the slides. I tried to keep it a little shorter, but that wasn't too bad. We have addressed some questions along the way, and I'm happy to take any other questions.
We have a follow-up question to the previous question. Do you recommend any tryptase level? Do you recommend tryptase level for any history?
Good question. You know, the Europeans who have been at the forefront of that field seem to be recommending it for everybody. There are certain markers. For example, if you get stung and you rapidly go into shock and unconsciousness, and you don't break out in hives, then there's a very high chance, 25 to 50% chance, that the tryptase is abnormal. So it's that drop in blood pressure that is most associated with the abnormal tryptase. So everyone who has a reaction with dizziness, lightheadedness, wooziness, or unconsciousness should have the tryptase level. The people who have other kinds, like throat tightness, trouble breathing, their chance of having a tryptase problem is less than 5% compared to the 25+% I said for the low blood pressure reactions, but it's certainly not zero. And it seems to be such an important marker of risk before, during, and after treatment that we're still, I mean, as an expert panel, I'm part of the group that writes the official practice parameters as guidelines for allergists and doctors, and it's a question that we struggle with, actually, because we don't want people doing blood tests all the time if they really don't need to be doing it. So what we recommend so far is that for sure it gets done in the severe reactors, and it's probably worth doing in the medium reactors. But if it's just hives and swelling, those relatively mild reactions, we're not so sure that it's necessary. So it's, again, I hate to keep saying judgment call, but that's the art of medicine. But those are the actual statistics that we have that help to guide us.
Great. Any other questions from the audience? You can raise your hand on the webinar, or there's also a question that you can go ahead and type in on the panel. We're happy to answer any questions that anybody has.
I'm going to pipe in while you see if there's any questions, because I mentioned that this one participant had sent in a few advanced questions, and I think I've answered, there were 4 or 5 of them, but there was one question I didn't answer, and this person's question was, actually there were a couple of questions. One of them was, is there a risk of biphasic reactions to venom? So for the non-allergists, a biphasic reaction means 2 phases. And that means that you have a bad reaction, it gets better, and then 4 to 6 hours later, it comes back again. And that's important in anaphylaxis because up to 20% of, especially the most severe reactions, are the ones that are more possibly going to be biphasic. In other words, if you have a bad reaction and you get treated and everything looks good after 2 hours and they send you home, that might have been a bad idea if you're home a couple hours and then everything comes back just as bad as it was before, which is why the recommendation to emergency rooms and doctors is that if it's that bad a reaction that they need epinephrine, they really should be monitored for 3 to 6 hours, depending how bad the reaction was. So the answer is yes, biphasic reactions can happen with venom. They seem to not happen as much. Certainly it's more typical with foods, maybe because the foods continue to be absorbed into your system. But the more severe the reaction, the more the chance, and it's important to be aware of that and be observed for a good while in case it comes back. If there's not a definite other question, then I'll go to the last question from this participant who asked.
We do have one.
Go ahead. Yes, I want to answer those first.
We have a comment and then we have a question. So
okay.
One is a comment and it says, "Thank you for expressing the need for epinephrine. I appreciate it." And then that was the comment. And then the question is, what is your experience with patients not tolerating venom immunotherapy?
Amazingly good. I've had more problems with grass shots and cat shots than I've had with venom shots. And that's pretty much the experience of allergists in this country and around the world. On the other hand, people do get bigger swellings in their arm when we give them the shots. And we have to try to tell people in advance that it's common to get swelling. Try to put up with it. It's not dangerous. It usually gets better as the shots progress. And it's unlike cat or grass, which are bad allergies. This one's life-threatening. It's important, I said earlier, to reach the full dose instead of holding back the doses. And sometimes we do try things to minimize those swellings, including medications, or sometimes we try to give half the shot in each arm if we can. But as far as systemic allergic reactions like anaphylaxis, it's like any other allergy shot, and it can happen. It's important. It's important for people to state that it must be done in the presence of a trained healthcare professional who's experienced in recognizing and treating anaphylaxis, because there's a chance that any allergy shot at any time can cause an anaphylactic reaction. It's mainly during the build-up stage, but because once they're on their booster shot every month, there's a really minimal chance of a severe reaction, but it's never impossible. And that's just a matter of making sure the person stays in the under observation for at least 30 minutes, and that they understand that if they feel funny in any way, they should let us know right away so we can check them. Fortunately, like I said, it's been pretty uncommon for allergists to have to treat a reaction with epinephrine for reactions to these shots. Considering how bad the allergy is, they're surprisingly safe.
Great. That wraps up all the questions. Unless we have any final questions, I just want to thank Dr. Golden once again for his excellent presentation. And it was very informative and comprehensive, and I want to thank all the attendees for your time and your interest in this subject matter. And you'll all receive a survey. If you wouldn't mind filling that out, we would greatly appreciate it. We'll also send you a copy of the recorded webinar. So with that, I'm going to let everybody go for the evening. I wish you all a wonderful evening. Good night, and thanks again for your time.
Thank you.